Thank you. So I want to thank Dr. Lin, Wei Chin, and his team for inviting me. And a big shout out actually really to Wei Chin and Yok Ching for having collaborated and helped look after many of our complex neurological patients, including the amyloidosis patients. So I'll be talking today about the neurological manifestations of amyloidosis. It's important to know about amyloidosis because there are available therapies and diagnosis is often delayed due to a variability of presentation, which includes a myriad of neurological manifestations. Amyloidosis can be classified as hereditary or acquired, and of these many causes, transthyretin is the most common inherited variant worldwide, as you have heard of, with an estimated global prevalence of neuropathic hereditary ATTR more than 10,000, while AL amyloidosis is the most common form of systemic amyloidosis to affect the neuromuscular system, with a prevalence of about 2.5 per 100,000. I will therefore be focusing more on these two types of amyloidosis in my talk today. Transthyretin gets its name from being a transport protein for the thyroid hormone and the retinol binding protein, and the protein is produced in the liver with small amounts synthesized outside of the liver in the eye as well as the choroid plexus. The protein normally circulates in a tetrameric conformation of 4 TTR proteins, but a mutation in the TTR gene results in a destabilization of the tetramer, leading it to dissociate into monomers which misfold and aggregate into insoluble amyloid fibrils, which deposit in various organs, including the nervous system, leading to damage, possibly by effects from blood vessel damage, mechanical compression, or inherent toxic effects. Amyloid can be found in all areas of the nervous system, including peripheral nerves, autonomic nervous system, and the central nervous system. And under the microscope of a nerve biopsy, amyloid nodules can be found in the epineurium, perineurium, as well as the endoneurium. We see here the typical pathological features of amyloid, which is congophilic and shows apple green birefringence with a polarized light. There is a great genetic and phenotypic heterogeneity where there are more than 140 different TTR mutations, which you can actually access on this website here. Worldwide, the most common mutation is the substitution of methionine for valine at position 30, or the val30 MET mutation, where p-val50 MET is the new nomenclature. There is also a great heterogeneity in the clinical presentation between the different genotypes, and even within the same phenotype, for example. P-val50 MET amyloidosis can manifest as an early disease onset in endemic areas in Japan and Portugal, while the P-val50 MET individuals of similar ancestry in non-endemic areas or of other ancestry actually has an older onset of disease. Some studies have also reported a gender difference where men may be more severely affected than women, and a difference in genetic phenotypes and the age of onset are also seen within family members and even are seen among monozygotic twins. This variation in disease onset and differing phenotypes are therefore likely not only due to genetic factors, but also from non-genetic modifying factors. Neurology manifestations of TTR involve both the peripheral and the central nervous system. The PNS or peripheral nervous system involvement is more common. Myopathy and spinal stenosis are less well described. Myopathy and TTR amyloidosis in particular is less common than its occurrence in AL amyloidosis. Spinal stenosis, such as lumbosacral spinal stenosis causing lumbosacral radiculopathy, is a common occurrence due to the infiltration of amyloid into the ligamentum flavum. The hallmark of peripheral nervous system involvement in amyloidosis includes a triad of carpal tunnel syndrome, autonomic neuropathy, and presence of polyneuropathy. Peripheral nervous system involvement can be focal, as in carpal tunnel syndrome, diffuse, as in sensory motor polyneuropathy, or in involving the autonomic nervous system, or it can be involving various combinations of all three. The carpal tunnel syndrome tends to be more severe and bilateral, with a progression or recurrence even after surgical release, and this is due to amyloid deposits in the transverse ligament. Autonomic dysfunction can lead to gastrointestinal symptoms like gastroparesis, which results in drastic weight loss, although there can be sometimes amyloid deposition in the muscularis mucosa. Milder autonomic neuropathy in late onset disease may be because of more progressive cerebral compensation rather than a less effect over the autonomic nervous system. As mentioned, familial amyloid polyneuropathy with the same p-val50 MET mutation can present either early or late in onset. And I think there was a slide of this in Prof. Roger Fu's talk. An early onset first presents with a dissociated sensory loss, with a predominant loss of pain and temperature sensation before the patients go on to lose their proprioception and develop motor weakness. In late onset disease, the proprioceptive and motor loss occurs much earlier in the disease course. And this is a table that shows the differences in the age of onset of symptoms, penetrance, and the pattern of neuropathic symptoms as discussed. Of note, a late onset is associated with a lower penetrance and therefore a frequently absent family history. Apart from the typical presentations, there are various atypical ways of presentations, including a polyradicular neuropathy, akin to a CIDP or GPS phenotype. It can also present as a predominantly upper limb form, a pure motor form that mimics motor neuron disease, a rapidly progressive form which may make you think it's a GBS, or an ataxic form where the patient presents with ataxic gait as well as sensory ataxia. Amyloidosis is known as the great imitator and can mimic other neurological diagnoses, as seen here where patients looked like they had amyotrophic lateral sclerosis when they actually had TTR amyloidosis, even down to the scalloped and wasted tongue with the tongue fasciculations. Familial amyloid polyneuropathy is also frequently misdiagnosed as chronic inflammatory demyelinating polyneuropathy or CIDP, where the misdiagnosis can be as high as 20% because of similar features on NCS and on CSF findings. Some clues to suggest a FAP over a CIDP is that pain may occur more frequently in patients with amyloid neuropathy, but only in 1/3 of patients with CIDP. And autonomic symptoms can occur in 65 to 94% of patients with amyloid neuropathy, but only in up to 20% of patients in CIDP. In this Italian study, they reviewed the medical records of 150 patients with ATTR over a period of about 13 years and listed the various misdiagnoses that some of the patients had. Of note, the more common misdiagnosis was CIDP as well as lumbosacral radiculopathies. And you've heard from Yoching about some of the red flag symptoms for amyloidosis, and this includes a positive family history, a progressive polyneuropathy of uncertain etiology, which may be out of proportion to the degree of any risk factors the patient may have, and that includes mild diabetes. With an association with the other two of the triad of neuropathic symptoms and signs, which are carpal tunnel syndrome and autonomic dysfunction, and other red flags would be to look for an association with other constitutional signs or signs of other systemic involvement, such as involving the heart, kidney, or the eye. As an illustration, here I have my patient who was a 55-year-old man who started having multiple spinal surgeries from 1992 because of recurrent L4, L5 spinal stenosis. He then developed a rotator cuff tear and developed sensory neural hearing loss, and then developed loss of weight of 20 kilos over a period of 2 years and was extensively investigated for underlying malignancy, which was negative. He developed giddiness and postural hypotension in 2017, which was attributed to iatrogenic causes, and a hormonal workup was normal. He was noted to have hypertrophy on echocardiogram in 2017, and note that his onset of symptoms was actually in 1992, and this was part of the workup of his giddiness. He was seen by a cardiologist and diagnosed with hypertrophic cardiomyopathy, but was discharged from follow-up. He finally reached the neurodiagnostic lab because of persistent numbness that was not better after surgery. An autonomic symptom review showed that he actually had autonomic symptoms, including constipation alternating with diarrhea, early satiety, postural giddiness, and reduced sweating. And a family history revealed that both his father and paternal aunt also had died from heart disease following a dramatic weight loss. And the electrodiagnostic exam was consistent with bilateral carpal tunnel syndrome and a severe sensory motor axonal peripheral neuropathy. So he did fulfill all the red flags: positive family history, association of progressive polyneuropathy with two of the other triad of carpal tunnel and autonomic dysfunction, and association with many constitutional signs and symptoms, including heart problems, tendon rupture or rotator cuff tear, recurrent lumbar spinal stenosis, and sensory neural hearing loss, which is probably from amyloid deposition. And so he was sent for genetic testing after his cerebral nerve and vastus lateralis biopsy was positive for amyloid. And it was indeed positive for a known pathogenic mutation, which is in this p-arginine 54-threonine alteration, which was first reported in the Chinese population. And he was started on fludrocortisone for his autonomic dysfunction and diflunisal, and finally tafamidis with slowing of his progression of his condition. Central nervous system involvement in TTR amyloidosis also occurs, but is less common. Its manifestations are more common when patients are treated with liver transplantation, as patients live longer and mutant TTR is still secreted from the retinal cells and the choroid plexus. The MRI may show leptomeningeal enhancement as seen by the arrows, and may also show superficial siderosis, which is a sequelae of subarachnoid bleeding due to the meningeovascular amyloid deposits. CNS sequelae also may be seen in patients with milder phenotypes because they have a longer survival. There are many other types of hereditary amyloidosis, such as apolipoprotein A1 and gel-solin amyloidosis. Gel-solin in particular is interesting because it leads to progressive cranial neuropathies, particularly facial neuropathies, as you can see here with this lady with facial asymmetry. And they can have corneal lattice dystrophy or cutis laxa, which is very lax skin, as you can see here on the face or on the neck. Pardon me. The two most common forms of systemic amyloidosis, which is monoclonal immunoglobulin light chain amyloidosis, or known as AL amyloidosis, and wild-type transdirected amyloidosis are acquired. And the AL amyloidosis is the most common systemic amyloidosis to affect the neuromuscular system, while ATTR wild-type is the most common systemic amyloidosis. AL amyloidosis is due to the underlying clonal plasma cell dyscrasia, which produces the monoclonal immunoglobulin light chains that aggregate to form fibrils. Again, this results in the triad of peripheral neuropathy, autonomic neuropathy, as well as carpal tunnel syndrome. Compared to TTR amyloidosis, the neurological manifestations are more peripheral without central nervous system involvement. And is there a way to tell apart TTR and AL amyloid neuropathy? The most common neurological presentation is similar in both. A distal symmetrical sensory predominant neuropathy that progresses to involve the motor nervous system and also have non-nervous system organ involvement. However, pan-neuronal involvement involving the motor nervous system occurs earlier and more often in TTR than in AL cases. And non-neuronal organ involvement, such as the heart and kidney in the first year of onset, is more often seen in AL cases than TTR cases. TTR neuropathy is also more associated with more severe autonomic failure. I'd like to illustrate this with a case. This patient was an 80-year-old with only a history of hypertension on diet control. She was actually first referred to us for bilateral hand numbness, and an NCS was requested for. But at the same time, the polyclinic very astutely picked up that she had nephrotic range proteinuria and had sent her to the renal physician. Myeloma panel showed that she did have an IgG lambda band, and the free kappa lambda ratio was also low. Renal biopsy was pursued because the renal physician felt that proteinuria was out of proportion to the degree of hypertension. And eventually, nerve conduction study did show that she had a bilateral carpal tunnel syndrome with a mild sensory motor axonal neuropathy on the background of what she was eventually diagnosed to have, multiple myeloma, with the renal biopsy showing AL amyloid. Like TTR, there are atypical presentations of AL amyloidosis in neuromuscular manifestations as well. And this includes multiple cranial neuropathies, a CIDP-like picture, multiple mononeuropathies, lumbosacral radiculoplexopathy, and amyloid myopathy. Of note, the entity of amyloid myopathy, while rare, is more common in AL amyloidosis than in TTR amyloidosis. Amyloidosis-associated myopathy is usually associated with involvement of other organs apart from the muscle, like heart, peripheral nerves, kidney, liver, or GI manifestations. And it may also be helpful to look for other cutaneous manifestations such as peripheral edema, alopecia, dystrophic fingernails, or macroglossia. Amyloid myopathy can manifest with muscle weakness. Some patients have an axial myopathy, or in tight, painful muscles where they have difficulty opening the mouth, where they call it like a fish mouth. Estimated 1.5% of patients with AL amyloidosis will eventually develop a myopathy. The other common acquired amyloidosis is the TTR wild type, which mostly involves the heart, leading to heart failure and atrial fibrillation. Peripheral neuropathy is less common, and there has been no nerve biopsy proven case of an ATTR wild type amyloid neuropathy. Neurological manifestations, if occurring, would be largely carpal tunnel syndrome or lumbar spinal stenosis, and the occasional case reports of myopathy. Other acquired amyloidosis, like AA amyloidosis or beta-2 macroglobulin, rarely have neurological manifestations. To sum up, we've gone through the various types of amyloid and some of their clinical features with an emphasis on neurological manifestations. Manifestations in the nervous system are more common in inherited ATTR mutated or inherited ATTR, which are less common in AL amyloidosis, while the heart manifestations are predominant in the AL and wild-type ATTR wild-type patients. This diagram illustrates that similar multiple organ systems are commonly affected in the different types of amyloidosis, but there may be certain features that distinguish some types more than others. For example, all of them may have gastrointestinal, cardiac, or autonomic or carpal tunnel. However, periorbital, purpura, and macroglossia may be seen in AL amyloidosis, while cutis laxa may be seen more in gel-solin amyloidosis. And I end off by referring you to a table showing the clinical red flags to clue you into a possible diagnosis of amyloidosis when the patient presents with a neuromuscular syndrome. Some take-home messages. It's important to recognize amyloidosis as management options are now available, which I think my fellow colleagues will go through. Transthyretin and AL amyloidosis are the more common entities of amyloidosis, and the neurological manifestations can be described as the triad of carpal tunnel syndrome, peripheral neuropathy, and autonomic dysfunction. One should bear in mind the clinical red flags for amyloidosis because symptoms can be very nonspecific. Thank you.